who in their 50s and 60s and 70s, maybe aggressively trying to take calcium and exercising and doing all these other lifestyle things to improve their bone strength, the ship has sailed. It was really your early life where peak bone mass was achieved. And that's, how you explain to people who are like, oh, why do I have this condition all of a sudden at age 65, 70, whenever the screening test may have happened. So most of the determinants of our peak bone mass are really hereditary, 70 to 80%, and then 20 to 30% are lifestyle. And lifestyle, we're thinking about, exposure to concerning medications, malnutrition, eating disorders. Those are the other risk factors. Osteoporotic fractures, are a big deal. We've spent a lot of time focusing on stroke, MI, breast cancer. But if you think about all the incidents of vertebral and non-vertebral fractures, it can be almost 2 million. This is back in 2013. For full disclosure, technically, this is a pharmaceutical company who I think developed Forteo or teriparatide. So that's what they were using for publicity. The other important thing is, this is proven in previous studies, is that your incidence of a second fracture is the highest in the first year after your first fracture. So this is your relative risk of having another subsequent fracture and the time in years. And you'll see that capturing the attention of the patient after that first non-traumatic fracture is very, very important. And that's where, we are actually developing a fracture liaison service informally at Mount Sinai, Morningside, and West. Some of you are involved in that quality improvement initiative to really get patients who are admitted with a hip fracture, some other non-traumatic osteoporotic fracture, to get them to see endocrinology or rheumatology for screening. So diagnosis, the Dexa diagnosis is based on a T-score of -2.5 or below. Osteopenia is -1.0 to -2.5. Patients who have osteopenia, we additionally use a FRAC score, which is an online calculator with race and country-specific algorithm built in, and you can plug through it to understand what the patient's 10-year risk is of having any kind of osteoporotic fracture or a hip fracture. So what is that fragility fracture? That's a question that often comes up, and you really have to get a very detailed history from the patient. So it's supposed to be a low trauma fracture, fall from a standing height. And that's hard to figure out sometimes. But whenever you hear stories, I was walking down the road, uneven pavement, I tripped, I fell, and I broke. Well, that is a low trauma fragility fracture. And no matter how much the patient is saying that, I fell on my left side, that's why I broke my left hip or my left shoulder, whatever it might be, it's not normal. Same thing at home. Somebody was walking, there was water on the floor, they slipped and fell and broke. It's a fragility fracture. If somebody is like climbing up on a chair or a ladder and somehow they fall, that is a little bit above ground. So there was a little bit of a, gravity related impact as well. So that might not be a fragility fracture. That sounds more traumatic. If somebody is walking down the stairs or walking up the stairs and somehow they tripped and fell, that's iffy. You'll have to probably pin down exactly what the question is, what the circumstances were. But you really have to find out, what the level of trauma is, and you kind of have to use your judgment. And what are the locations? So metatarsal or toe fractures or finger fractures don't really count. So I think of it as anything that is proximal to the wrist, including the wrist, and proximal to the ankle, usually you can include the ankle, that counts as a osteoporotic fracture location. So all those stress fractures that people commonly have in their feet are not pertinent. And also, not all low BMD on the Dexa is osteoporosis. It could have osteomalacia, you could have CKD, MBD, so mineral bone disorder because of low GFR below 30. You could have cancer-related lytic lesions. Primary hyperparathyroidism can affect bone density, especially in the forearm. So that leads to, the secondary workup that we will talk about. Another tool that is available at some institutions, we don't have that yet, is the trabecular bone score. And this basically uses your Dexa image, which is here on the left, and then there's a computer algorithm, and it gives you a trabecular bone score. So trabecular bone, the idea is, you're looking at a little bit more microarchitecture versus just cortical bone, which is the more density. And here you have the same BMD in these two patients, but this patient has a much lower trabecular bone score. And you can look at their little algorithmic image that is created. They do have worse bone density. So this is another measure that can be used to further differentiate and not solely rely on BMD from a Dexa, which is not a perfect marker of microarchitecture. So a low TBS is more concerning for low bone density. This has been available now for almost 5-6 years. I've been hearing about it all of my fellowship, which I started 5 years ago. So yeah, it's been out for 5 to 6 years. Some of the New York institutions have it, but not all. So who to screen? So the very basic recommendation is all menopausal women above the age of 65 and above should be screened. And all of the societies, the United States Preventive Services Task Force, the International Society of Clinical Densitometry, National Osteoporosis Foundation, American Association of Clinical Endocrinologists, everybody agrees on that. Then what to do for menopausal women between the age of 50 to 64? Well, if they have a risk factor, prior fractures, high-risk medications, such as steroids or aromatase inhibitors for breast cancer, any other diseases such as HIV. So if they have a risk factor, you should screen them. Perimenopausal, again, if you have risk factors, you can consider screening them. Men, most people agree that above the age of 70, you should at least do one screening Dexa. And premenopause, it's only with, if you have a fracture or on steroids, rheumatoid arthritis, rheumatology diagnoses, you could consider. But if we can even get everybody above the age of 65 getting screened in primary care, that will be a huge, huge importance. And it's amazing now that we're doing this QI project, multiple 75-year-old, 77-year-old men and women who have never had a bone density done. And then recently I saw some patients with a T-score of -3.5, which is severe osteoporosis, probably was there for almost a decade, but the screening test was never done. So how often should I have a Dexa? That's another question that comes up. For one thing, you should try to get the Dexa on the same machine, because every machine is individually calibrated, and doing it on the same machine allows you to do year-over-year comparisons. Medicare only pays for it every 2 years, so that's the general threshold. If somebody has osteopenia, should you ever repeat the study? Maybe in 5 years. And if you have a postmenopausal woman who had a normal Dexa between the ages of 50 to 64, they do not need to be getting the test every 3 to 5 years or every 2 years until the age of 65. In the past, I think a lot of OB-GYN and some primary care doctors were somehow doing a Dexa at age 50, 51. And if that is, not osteoporotic, you should really wait till 65. The peripheral DEXA. So in our institution, you'll see that at least the Mount Sinai DEXAs, I can't comment on the Ryan Center, but everybody gets both axial DEXA, which is your spine and hip, and also the peripheral DEXA, which is the distal 1/3 radius of your forearm. But really, the forearm should only be done if your spine or hip image is not reliable. The forearm DEXA is not as validated for year-over-year comparison, changes in level of BMD over the years. But, I don't know, it's like a Mount Sinai institutional thing. Everybody gets everything most of the time. And sometimes it creates problems because people might have reasonably okay or mild osteopenia in the axial images of the spine and the hip, and they might have disproportionately poor bone in the forearm. And then what do? You've done all the secondary workup. Parathyroid hormone is normal, which is classically associated with more forearm disease. And I've struggled with this. Do I really want to treat somebody with the forearm DEXA of, like, let's say -4.0, and then the rest of their hip and spine is -1.5? Then you really wonder if the quality of that bone or that image is reliable. And I have that discussion with the patient. You do shared decision making. If you want to trend it over 1 or 2 years before jumping to treatment or not. I mean, theoretically, they were diagnosed with osteoporosis. If you want to just strictly follow guidelines, you could treat them and you would not be wrong. But this is where it's the art of medicine to really figure out how frail the patient is. Are they falling, breaking things? Do I really want to commit them to medication too early? Some, DEXAs, we do the vertebral fracture assessment. And that's really indicated in your older patients. If there's a significant height loss, there's a known vertebral fracture, or if they've been on steroids for a long time. And you'll note here, it says, more than 5 milligrams. So when you have kidney transplant patients around 5 milligrams of prednisone, that's physiologic. So that should not be causing any additional harm to the patient. Another important caveat, this is just linguistics, I guess, partially. Anybody below the age of 50 or premenopausal, you're supposed to use the term low BMD for expected age, and you're supposed to use the Z-score. The terms osteoporosis and osteopenia are only for postmenopausal and older men. So that's just a minor point, and also a reminder to use a Z-score in these younger patients. And treatment in these premenopausal patients is very controversial. Again, you have to use clinical judgment. Are they frequently fracturing? What is the secondary workup? I've seen a few patients in their early 30s. They have had some, lower leg fractures, tibia, etc. They're athletic runners, and all of the workup for any kind of esoteric stuff is normal. Then you have to again discuss, do I really want to put them on medication versus just optimizing calcium and vitamin D? So those situations will exist, and you should probably be referring them to endocrinology, so you don't have to make that call. But these situations exist. So what types of history questions do I ask all of my patients? I ask women about their menstrual history, pregnancies, menopause. Estrogen is protective to the bone, so that's why that's important. Hypogonadism in men, low libido, any prior low testosterone, testosterone replacement, that's important. History of fractures, site, age, cause. It's really the fractures after the age of 50 that matter. And if somebody had a fracture younger than that, I don't count that against them unless it's multiple fractures. And then really thinking about, stress fracture in the feet, traumatic fracture, osteoporotic fracture. family history of osteoporosis or hip fractures, falls, what is their calcium and vitamin D intake, both in their diet and any type of supplements. Was there any kind of malnutrition, malabsorption growing up? Did they grow up in some, different parts of the world where they might have had less access to calcium or vitamin D, or nutritionally challenged? Important to ask. Exercise is just to know, how active they are. Are they, do they have any concerns about balance, core strength? When they ask me about exercise and they have a diagnosis of osteoporosis, I tell them they can do everything. Really focus on the core. Don't lift, more than 10 pounds above the neck, because all of that weight, a lot of that stress goes onto your spine, and then you could theoretically have compression fracture in the spine if you already have an osteoporotic spine. Other risk factors to talk about, like I said, eating disorder, poor nutrition, dieting. Coffee, unless there's crazy amounts, is probably fine. I really think about if it's more than 3 cups a day. And there's really no clear signal for it. Excessive phosphate intake. So where does that come from? It really comes from dark soda on a common basis. So Coca-Cola and Pepsi have phosphorus. Sprite, 7-Up, ginger ale don't. And the idea here is that if you're on a very high phosphorus intake, the calcium will bind to that, and you might be having some calcium deficiency internally, which might not show up on blood test. Speaking of which, whenever your patient says, oh, my blood calcium is normal, that's all that matters. Well, that's not true, because our body will do whatever it needs to maintain serum calcium. But if you're not getting adequate dietary or supplemental calcium, the calcium is obtained through bone breakdown, which is worsening osteoporosis. And then talking about liver disease, thyroid disease, kidney disease, again, risk factors for osteoporosis, hyperthyroidism, kidney problems with absorption, filtration, renal osteodystrophy. Kidney stones could impact medication options, chronic diarrhea, prolonged immobilization. That can cause elevations in calcium, possibly just less strength of the bone, more brittle bones. Radiation treatment, again, is important because of treatment choices and also because of just more fragile bones. Loss of height, to think about, is there a need to do any dedicated spinal imaging for vertebral height through plain x-rays, possibly. Steroids are the common medication we think about. Prednisone doses, usually 7.5 milligram or more for more than 3 months continuously. Anticoagulation, and I think it has a very minimal impact. I think it's heparin of all the things, which we're really not using a whole lot outside of the brief inpatient stays. Thyroid medication, again, here we're thinking about hyperthyroidism. PPIs, I'm going to have a slide about this after. Controversial. If you're on it chronically forever and ever, maybe it's not ideal. And here too, I think it has an impact on calcium absorption. So you think about using calcium citrate for better absorption rather than calcium carbonate. Seizure medications, really small impact. I can't even remember the exact mechanism. Tobacco and alcohol are important for really nutritional issues from alcohol, and tobacco has some direct impact on the bone. So secondary causes, so what do we think about? From an endocrine standpoint, common things are hyperthyroid, hypogonad, hyperparathyroid, most common thing we worry about, hypercortisolism, including what was formerly subclinical Cushing's. Now we call it autonomous cortisol secretion. MACE is the official term for that. Nutritional stuff, as we were discussing, all these different drugs, heparin was the anticoagulant, and some other conditions. So it's a lot of secondary causes. So speaking of PPIs, there's been lots of studies going back and forth on it, but overall, there might be some signal with some PPIs and fracture. So if you really need somebody to be on something for acid reflux and GERD, H2 blockers are safer. So I put them on famotidine or Pepcid rather than some kind of PPI. Other drugs that we think about, as I was mentioning, breast cancer, aromatase inhibitors, you really are supposed to do a Dexa scan at start of therapy and then monitor that every 2 years. And there's more and more data to just put somebody on treatment with some type of bisphosphonate or denosumab if they are on aromatase inhibitors and the T-score is negative 2.0 or lower, or if they have an elevated FRAC score. And there's a lot of data for zoledronic acid and denosumab and even alendronate for improving not only bone health, but also reducing cancer involvement in the bone and overall disease-free survival. So what are the routine tests that I do? So, in my smart phrase templates, if any of you have rotated in endocrinology, so everybody should get a CMP, phosphorus, vitamin D. I usually do magnesium, but really not that important. Everybody should get a parathyroid hormone. Some would argue that you should wait for an elevated calcium before you check it, but there's a lot of normal calcemic hyperpara. So it doesn't hurt to check. I usually do a TSH in everybody. Rest of this I don't always do, except SPEP I will usually throw in. And the bone turnover marker, my preferred marker is the serum CTX, C collagen peptide. So those are my routine things. CBC I don't usually do, but almost always you can find a hemoglobin somewhere. 24-hour urine calcium I used to do always, but it's very cumbersome. So I don't always do that. It's in very specific situations that I consider that. And yeah, the prolactin, there's really no need. Celiac I do sometimes in younger patients if they have very poor bones and we're not sure. So I throw in a TTG for that. Testosterone I check in men. If they're hypogonadal, we should really be addressing the hypogonadism to help with bone health. Cushing's also, I leave it for my younger patients when I don't have answers, and I'm really looking for that, subclinical Cushing's, which is really, a dexamethasone suppression test where the cortisol does not fully suppress to less than 1.8. But it's also not overtly high, above 5, which is diagnostic for true Cushing's. So somewhere between that 1.8 and 5. And you will catch a couple of patients. Skin biopsy, or bone biopsy is the gold standard when you're trying to differentiate if somebody has CKD MBD. Another term for that sometimes is renal osteodystrophy, which is a little bit different. But this applies to your patients with a GFR that is less than 30. And I often have a discussion with the nephrologist about what they're thinking from the bone health of the patient, how much of it is really metabolic mineral abnormalities because of low GFR versus truly a bone health issue. So as I was saying, there's three bone markers, I guess, that we think about. The common things you may have seen are the NTX and the CTX. So my preferred is the CTX. It's serum, easy to do. NTX is usually urine. And I think that's just my training. I was trained in using the CTX. And then P1NP is another marker. It's more of a bone formation marker. So it's helpful if you're thinking about some type of anabolic therapy to have that at baseline versus post-treatment. And that's what I use the bone turnover markers for. Just if somebody has a high baseline serum CTX of, let's say, 600, 1,000, whatever, and that's not going to influence my decision-making. So decision-making is really still based on Dexa, based on the clinical history of fragility fracture, but that baseline CTX is useful. If the patient is on treatment, then we can reassess what happened to that CTX. So a couple of key points about Dexa, it's standardized to the T-score of a white female aged 20 to 29, regardless of who your patient is. All women and men of all ethnic groups are standardized to that person. And we talked a little bit about most of this. Inaccuracies, this is very important. I always try to look at the images of the bone density whenever I can. There are a few occurrences where instead of L1 through L4, they accidentally looked at T12 to L3, which will have an impact. Or if there's a lot of scoliosis, then the spine is not reliable. If there's a lot of deviation between the individual vertebrae, more than 1 point, then those vertebrae have to be excluded. Hip as well, it really has to be linear with a little bit of internal rotation or external rotation that you can see the lesser trochanter, because we're making a lot of big life-altering decisions, at least 5 years of treatment possibly, based on some of these reports, and all you see in the report is T-score is this. They don't even put the BMD number. And it's a disservice to your patient to not ensure that the data is reliable. And I've had several instances where the data has not made sense, so it's useful to look at the images. And this was that fracture risk assessment tool. I think it was, the link was put in the chat. And what you'll see here is you can just go through all of this routine information to come up with a FRAC score. Let me see. Okay, so one thing I wanted to highlight here, you do not need to put anything in 12. You can leave this blank, the bone density information, and still calculate a FRAC score. So you can still get information while you're still waiting for the Dexa. And here's that tool. If somebody has a TBS, trabecular bone score, you can further adjust this score. And it's useful to play around with how this works. And what you want to do is you kind of want to see how age impacts things, if you're like on the fence about treating or not treating. Recently, I saw an 82-year-old who had her lowest T-score was negative 1.7 at the femoral neck, and the rest of it was okay. Severe scoliosis, not frail, not fracturing, but her FRAC score was negative 3.4. And for a Caucasian woman in the US, the threshold for FRAX-based treatment in osteopenia, when that patient is osteopenic, is 20% for major osteoporotic fracture and 3%. So if I just go by osteopenia, elevated FRAC score at the hip of 3.2%, well, she meets criteria for treatment. But looking at her, I was like, well, you're not frail, nothing else going on. And we elected to not treat. And that might not be the right answer, but I was comfortable with that and the patient was comfortable with that. And I think what was really influencing that elevated FRAC score was age. If I put in the same BMD and all of the other data 5 years earlier, she would not qualify for treatment. And my thought was, if we do this for every 82, 85-year-old, everybody's going to be on treatment. So you kind of have to take certain things are just natural part of life and really have to think about putting everybody on medications, because they will all have some degree of osteopenia, and just age alone might put them at an elevated FRAC score. So this is one of the cases. Let's do a couple of cases and then I'll have some more information afterwards. So 61-year-old Caucasian male having back pain, found to have a compression fracture on X-ray, also with NSIP, so interstitial fibrosis, and started on prednisone, now weaned down to 10 milligrams, has family history of both osteoporosis and hip fracture, some personal wrist fracture, but that was a fall from a ladder. Height loss, a lot of kyphosis on exam. But the Dexa looks pretty good. So what to do? So this is the type of patient. Osteoporosis is defined because of their compression fracture, and they have a lot of other stuff going on. Steroid use, family history. So the Dexa, to give you an example, is not as reliable in this patient, and you still want to think about treating them. And we did put this patient on treatment because of their compression fracture and risk factors of steroid use, etc., for more fractures in the future. Another example of a 62-year-old woman, breast cancer, surgery, radiation, aromatase inhibitor, really no other risk factors. And here I wanted to highlight that you want to get that baseline bone density, get all of the labs, calculate their FRAC score. Actually, the FRAC score, I'll get back to that. So just looking at the Dexa, she has osteoporosis. So she should be on treatment, and she was started on a bisphosphonate for treatment. The reason I put the FRAC score here is the FRAC score in this situation can be misleading because it's relatively low. I said 20% and 3% are the thresholds. But the FRAC score is only to be used in a patient with osteopenia. This patient has true osteoporosis, so there is no reason to check a FRAC score and cloud your judgment. So that's the point I wanted to make here, because it can be misleading as well. So let's talk about treatment. So who to treat? So anybody with a osteoporotic fracture, low T-score, and these were those FRAX thresholds if somebody has osteopenia. And equally important is, shared decision-making. Is there a high risk for decline in BMD? Is BMD declining on serial Dexa? Is there a new fracture? What is the risk-benefit safety profile of the medications for that pertinent patient? Universally, everybody should get calcium. So at least 1,200 milligrams for most of our 50 and above patients. At least 1,000 usually of vitamin D, but that can be modified based on the vitamin D level. Exercise, we talked about core strengthening, not too much above the neck. Fall prevention, refer to physical therapy if needed. Stop smoking, avoid alcohol. And this is a summary slide from my mentor at Penn, Dr. Al-Muqaddam, about your treatment approaches. So you should do calcium, vitamin D, exercise, fall prevention, nutrition, stop smoking. And then you want to think about what types of medications we have. So we have medications that are anti-resorptive. They are reducing bone resorption by osteoclast. And these are your bisphosphonates, oral or IV, denosumab, which is Prolia, every 6-month injection. Calcitonin, controversial, we don't really use it for osteoporosis, but it does have some impact. SERM, so that's selective estrogen receptor modulator, and we're really talking about raloxifene that we sometimes use, Avista. That's, if somebody's in their early 50s, they're kind of having some symptoms of menopause, or OB-GYN starts those sometimes, around breast cancer or, just perimenopausal symptoms. There's some data for its use for vertebral fracture prevention, but really not a whole lot of long-term data. So that's not your go-to for true osteoporosis treatment. And same with estrogen. Sometimes I have these young 50-year-olds, or even like a 65-year-old I saw recently was asking me if she should just take estrogen. And I'm like, first of all, if you are menopausal for more than 5 years, you should really not go on systemic hormone replacement therapy. Hormone replacement therapy is safer than we think it is. It can be used. It is underutilized, but it's really for that perimenopausal woman with hot flashes. that there's no indication to put everybody on HRT from a bone health standpoint, and definitely no point in introducing estrogen at age 65 to 70. But these types of questions come up. Romosozumab is the newest drug on the market, came out about 2.5 years ago. That's a sclerostin inhibitor. I only have one patient who has been on it. I haven't used it yet. It's my drug of last resort, I guess. I'm a little bit slow to adopt the newest medications when it comes to osteoporosis, I guess. But it exists, and it has both anti-resorptive properties and also anabolic properties. So these are your drugs for bone formation. And here we think about the classic daily injectable, teriparatide or Forteo, and abaloparatide or Tymlos. So until this year, both teriparatide and abaloparatide had a lifetime limit cumulatively to use for no more than 24 months. And there was a black box warning for bone malignancy. Both of these have been removed. So now you can theoretically use these drugs for an indefinite time frame. And the black box for bone cancer was removed because they were never seen in humans. It was only in rodents. So what is the efficacy of these drugs? So, here we have a table again from my mentor. So bisphosphonates, oral or IV. So hip fracture reduction is about 40%. Not enough evidence in the original trials for teriparatide and abaloparatide or romosozumab. Spine fracture is, anywhere from 50 to 70%. So zoledronic acid intravenous is closer to 70%. Denosumab is also almost 70. Your anabolic agents are 65 to 86. Romosozumab is 73. And as you'll see here, estrogen is very weak, which is why it's not the desired drug to consider when you have these more efficacious options available. So with bisphosphonates, we worry about oral ones, esophageal inflammation, esophagitis, or acid reflux worsening. You cannot use them if you have pre-existing strictures. With intravenous, you can have flu-like symptoms for a couple of days. With denosumab, you worry about maybe skin, soft tissue infection. And both bisphosphonates and denosumab have two shared side effects. One is osteonecrosis of the jaw. I usually quote about 1 in 10,000 people. More common with invasive dental surgery. So we're talking about extractions or implants. Not like your routine cleaning or bridge or Invisalign, that type of stuff. And the other risk is atypical femur fractures. And here we're talking about 1 in 100,000 people. The femur bone just snaps in half. It's very atypical, hard to predict. Post-treatment hypocalcemia can also happen. As you might know from inpatient work, we use these drugs also in hypercalcemia. And that can be mitigated by having an optimal vitamin D level, at least above 25 for 25 hydroxy vitamin D, and ensuring they're getting their 1,200 milligrams of calcium either through diet, supplement, or some combination. The daily injections, teriparatide, abaloparatide, are really well tolerated. Really nothing worrisome, but you cannot use it if you had bone radiation, if you have Paget's disease of the bone, or if you have a very, very high PTH level of your known hyperparathyroidism. The high ALP here is just an indicator for possible screening for Paget's disease, which is a different metabolic disease. It's just increased bone metabolism. Romosozumab does have a black box warning for cardiovascular precautions, which is why I haven't jumped the gun on using it. But this is your general idea of how these drugs impact, what type of decision making. So when I have a patient with a mild disease, I offer them oral, alendronate, once weekly or once monthly version, which is risedronate or Actonel. If I have concern for adherence, then I might give them zoledronic acid, which can be dosed every 18 to 24 months. You do not have to give zoledronic acid every 12 months. I think it's overkill. These drugs stay in your body for a long time. Prolia or denosumab, there is a risk of rapid reversibility if you do not get the injection every 6 months. So I'm careful about starting this on my non-adherent or my younger patients because there's no limit to using denosumab. You can take it for 10, 15, 20 years, and there is safety data for more than 10 years now. But I am wary because insurance might change, patients might move, and then there might be somehow a delay in their injection, and there's a risk of a rebound fracture. So that's my general conversations around those drugs. If I'm worried about severe osteoporosis, which is really a T-score of -3.5, or somebody is just frequently fracturing, then I might think about anabolic therapy with the daily injection, provided the patient is able to do a daily injection. Teriparatide, abaloparatide, if I'm going to start that, there is a theoretical risk of hypercalciuria. So this is when I think about checking a 24-hour urine calcium at baseline. And I stop doing it for all the patients, but if I'm going to start teriparatide or abaloparatide, I get that at baseline to ensure that we do not worsen hypercalciuria and increase the risk of kidney stones. So yeah, that's generally my spiel, when I'm talking about these drugs with patients. And I'm going to be honest, some treatment is better than none. So even if they can just take that weekly alendronate, it's still going to be beneficial. So you don't have to push them to the more potent therapies. And you can always go more potent later if the patient is not ready. In terms of order of treatment, it's usually better if you think the patient might need multiple agents. It's better to do anabolic therapy, the daily injections first, and then do anti-resorptive therapy. There's data to say that if you're switching from anti-resorptive to anabolic, you might not get as much of a benefit. Again, these are very advanced discussions. Probably endocrinology is seeing the patient, but just to give you some flavor. We'll skip some of this. Make sure the vitamin D is above 25. So ONJ, what are the risk factors? Poor dental hygiene, glucocorticoid use, cancer, smoking, diabetes. And this is where, I get really upset with the dentists who have created the stigma of scare around bisphosphonate therapy, denosumab therapy. Their own association, the American Association of Oral and Oral Maxillofacial Surgeons, suggests you can continue bisphosphonate if you're on it for less than 4 years, even prior to an extraction or implant, if you do not have risk factors. If you've been on therapy for more than 4 years, you stop it for 3 months prior to surgery. And the number of times, the patient is like, my dentist will disown me, or they will, not take care of me if I take these drugs. And I tell them, maybe the dentist should just manage your osteoporosis. There's not a whole lot we can do if they're not following their own guidelines and they're going by anecdotal data because they had 1 or 2 or whatever bad experiences. It's a little bit of frustration, when that happens, but this is their own guidelines that say you can continue these drugs. And when somebody says, denosumab is recommended by my dentist, but not alendronate or zoledronic acid, well, that's also misinformation because all 3 of those anti-resorptive agents have that risk of ONJ. So Prolia is not, or denosumab is not any better than that. So really try to educate patients when you get these types of barriers. Their dental societies are okay with these drugs. We'll skip some of this. We'll just go to oral hygiene. Atypical femur fracture. Whenever I see patients on these drugs, I ask them about any kind of groin pain or thigh pain. Then I consider doing an X-ray. It's more common in Asians and really after long-term use because these drugs really, are on the side of the bone. You see these white lines, very thick whitening because they deposit in the bone. That's what an atypical, just this weird horizontal almost fracture. And this is, I guess, pertinent to the QI study that we're doing at our West Side hospitals. Recently admitted with a hip fracture, femoral neck, what to do, never been on osteoporosis medications. There's enough data that the timing of drug, there's no difference in fracture healing. So you can start the drug within 2 weeks versus 1 month, not much of a difference. So you ideally want to see these patients soon, get them the screening, find out their baseline bone density on Dexa so you can monitor something and put them on treatment, most of them. And the idea was, should we be avoiding any type of anti-resorptive because it's going to reduce your osteoclast activity, so maybe some negative impact on bone remodeling, but that is not an issue. So you can pretty much use any drug you want for a post-hip fracture treatment. So I think we'll skip some of this so you have a couple of minutes for a question. So again, if you have CKD, if the GFR is less than 30, you really have to figure out if it's PTH, calcium, phosphorus, vitamin D. Do they just have, renal bone disease and not true metabolic bone disease or osteoporosis? We never do combined therapy. That's a question that comes up. It's really sequential, preferably. Duration of treatment is at least 5 years for any type of bisphosphonate. Lifelong for denosumab, teriparatide, abaloparatide, the daily injections is minimum of 2 years, and now you can continue them forever and ever. Romosozumab is 12 months injection of romosozumab, followed by denosumab for at least 12 months. So most people will be on treatment. And bisphosphonates are the only drug where you really have a drug holiday. You cannot really have a drug holiday with anything else. If you stop anything else, you have to have a plan of what you're doing. And one of the advantages of the CTX is if your early morning fasting CTX is less than 200 while on treatment, that tells me that the treatment is working and it is still in your system. And this is something I use when I'm trying to space out zoledronic acid. If at 12 months after treatment, their CTX is still low, well, let's recheck at 18 months. If it is still low, maybe we can give the second dose of zoledronic acid at 24 months rather than that initial 12 months, which people generally think about. Drug holiday, we kind of talked about. After 5 years, if the bone density at the hip is not less than -2.5, and if they're not a high fracture risk, we can stop bisphosphonates. Skip that. And what is success is generally stable to improving bone density. That's really what you're thinking about. One fracture while on therapy doesn't necessarily mean that it's failure. So really don't need to stop therapy or change therapy. So just, one quick slide. This is my last slide really, so you can start thinking about questions. Hypercalcemia, hyperpara, what to do. Really do confirmatory labs, albumin corrected calcium. I frequently do an ionized calcium, parathyroid hormone, vitamin D, GFR, magnesium, and phosphorus. You do not need to check PTHRP or SPAT or 125 hydroxyvitamin D unless you find out that the PTH is low. So it's a PTH independent process. And then you want to think about the other etiologies, lymphoma, malignancy, granulomatous diseases, or myeloma. You want to find out about calcium intake, dietary and supplements. You want to find out about kidney stones, fractures. You want to do a bone density, a 24-hour urine calcium. And then I usually defer any kind of neck imaging to the surgeons. And what is your surgical criteria? So treatment for hyperpara, primary hyperpara is preferred is surgical. Cinacalcet or Sensipar to reduce PTH is really reserved for patients who are not a surgical candidate, who are maybe end of life, who have parathyroid malignancy maybe, but it's not a great drug to be on for many, many years for primary hyperpara. Surgical criteria is age less than 50, calcium more than 1 point, the upper limit of normal, osteoporosis, hypercalciuria or with kidney stone risk, and chronic kidney disease, GFR less than 60. So that's really your criteria. So sorry, that was a lot of information in like 52 minutes. I apologize. I guess I have to cut these slides down a little bit more next time. But I'm happy to answer any questions that you might have, and feel free to email me with any questions that you may have.